Hello, everyone. This is Professor Al-Hazza. I'll be your director of this block. I'll actually be giving you 5 lectures in total, but I thought before starting the series of the 5 lectures, I wanted to do a little orientation and instrumentation because in ophthalmology, the instrumentation is really an integral part of our if you will, ophthalmology course. So I'm going to be starting your orientation. The objectives of this course is I'd like you to know, I'm going to be teaching you the basic ophthalmic anatomy and physiology, simply to recognize and assess common ophthalmic disorders. I'll be showing you some simple diagnostic instruments, and then in some of the diseases, I'll just show you what the principle of the management of these common ophthalmic diseases. The 5 lectures will be 1, visual impairment, 2, red eye, 3, common eyelid diseases, 4, pediatric ophthalmology and ocular motility, and last but not least, the systemic diseases and the relation to the eye. So as I mentioned, as ophthalmologists, we have a lot of instrumentation. I mean, without our instrumentation, we would not be able to more or less do a good clinical exam, clinical diagnoses, and further management. So as you see in the slide, that's a lot of instrumentation, and that's not even all of them. Why should you, as a student, be interested in the eye? It's part of your course, of course, but technically the eye is unique. If you look at the emergency, we always say it's preservation of life, preservation of limb, and preservation of eyesight. So it tells you more or less that the eyesight is an important function within your organs. So usually as ophthalmologists, we are all surgeons. So we are not just ophthalmologists, but we are ophthalmic surgeons. So if you ever choose to be an ophthalmologist, you do have to be a good surgeon. All right, so if I was to tell you, if there is a barrier between the examiner and the patient, it's between me and my patient, and that barrier only would give you 1 square inch through which the examination can be performed, which square inch will you choose? Diagnostically and functionally, the eye is the most important square inch of the body surface. If you see that little opening there, that little inch there is probably the most important part of your body surface. So, of all the organs of the body, the eye is the most accessible to direct examination. The external anatomy of the eye is visible to inspection with the unaided eye, and it's really with fairly simple instruments that I'll be explaining to you. The health or disease of a large portion of the body can be determined simply by looking at the eye. This is why they always say the eye is the window to your body, and it's simply through that little opening, the pupil, which I will be explaining, where you can actually see the retina and the optic disc, which I will be explaining. So, and the eye is actually connected with the rest of the body. Therefore, it reveals an enormous amount of general information, and it's the only part of the body where blood vessels and the central nervous systems can be viewed directly. So through the naked eye, I can actually see the nervous system through the optic disc, which I'll be explaining, and all the blood vessels. As you know, we do have 12 cranial nerves that really provide a large part of our information about the brain. What I'd like you to concentrate on is really more or less 6 nerves. Cranial nerve 2, which is the optic nerve. Cranial nerve 5, the trigeminal. I'd like you to study the different branches of it. Cranial nerve 7, which is the facial. Then, of course, you have your cranial nerve 3, 4, and 6. And I've highlighted those in yellow because those are really more or less also the eye nerves. And we're going to be studying more about it when I go into strabismus and teach you the different motilities of the eye. Also, the cranial nerves, they provide information about your autonomic pathways. So please read on your sympathetic and your parasympathetic pathways. Very important to have a ground and solid basis. So the more you read, the more you will actually understand ophthalmology. All I can do in this next half hour as an introduction is simply just give you the key points and bullets, and your job is to really read in depth. So if we talk about the optic nerve, it's the best known connection between the brain and the eye. The visual pathways extend from the front to the back across the brain, and it can really be studied easily and safely using what we call perimetry, or what we also refer to as visual field testing. You test your visual field. It can also, your optic nerve can differentiate accurately between lesions of the temporal, parietal, and occipital lobes. This is a very old drawing. I really do like it, but it just shows you the retina is really not here. They're pointing to the vitreous. Your retina is this very thin area here. It shows you your optic nerves, and then it shows you your primary visual cortex. I always like to use this because it is, although very primitive, but they were right on the spot. So let me talk a little. We talked a lot about the optic nerve. You don't see the optic nerve when you're examining the retina through an ophthalmoscope, which I'll be showing you, and through the pupil. What you actually see is simply the optic disc, and it's right there. You see that optic disc? This is what connects to the optic nerve, and then connects, and then goes through the optic chiasm, and then ultimately to the brain. You're going to be hearing me talk a lot about macula. So if this is your optic disc here, this is the actual part, the back part of your eye. So if we talk about the optic disc, this is what the macula is. The macula is in the center of your retina. The macula is in charge of your central vision. And the fovea, which is in the center of the macula, is in charge of your fine vision. This is just a drawing. It's actually from an OCT. You're going to be hearing me talk about that. When I talk about OCT, it's optical coherence tomography. If you think of the MRI, where it takes slices of the brain, the OCT actually takes slices of your retina. And this is what you're seeing here. This is the 11 layers of the retina. This is your macula, and then your fovea is in the center. And of course, under your retina is your choroid, and under your choroid is your sclera, and that is the white part of the eye that we can see through the naked eye. So if we talk about the optic nerve, really two important things for you to know as a medical student, and then later when you become an intern, even though you don't go into ophthalmology. You have to know the term papilloedema, and you have to know the term optic atrophy. You can see the difference between these two. If we go back and see this nice normal optic disc, you can see the contour. I can actually trace it. It's nice and orange with a nice optic cup. And you can actually trace, if you can see, all the vessels very easily and nicely. This is your normal optic disc. What happens when your optic disc is swollen, or what we refer to as papilloedema? As you can see, I cannot trace it. I don't know where the borders are. You see a little hemorrhage there, which is abnormal. And also another important thing is I cannot even trace the vessels. They tend to disappear and then appear, disappear and then appear, disappear and then appear. This, interestingly, is what we refer to as papilloedema, and this is what we refer to also as increased intracranial pressure. If you look at the bottom, this is what we refer to as optic atrophy. And unfortunately, even though you can trace the contours really nicely, you can actually trace every single vessel, but it is pale because the nerve fibers are damaged at the level anywhere from the retina to the lateral geniculate body. And please look up the lateral geniculate body and read on it further. Now, when we talk about the third, fourth, fifth, and sixth nerve, these you can evaluate through the brainstem, cavernous sinus, and the apex of the orbit. So please go back to your anatomy and know the course of these nerves, the third, fourth, fifth, and sixth nerve. Really very important. Study your cavernous sinus, and you should be able, after you read, to be able to identify what 1, 2, 3, 4, 5, 6, 7, and 8 is. Really very important. So 90% of our information reaches our brain through the sight. Unfortunately, of all the parts of the body, the eye is the most vulnerable to minor injury because it's exposed. So if anything comes flying, a ball, a tennis ball, God forbid, an instrument, the first thing, because we tend to look at whatever's coming towards us, therefore you have your eye as the point of injury. So we're going to be talking a lot in our 5 lectures. I'll be presenting to you about visual acuity testing. So I just wanted to display these different testings. Of course, for us here in Saudi Arabia or in the Arab countries, because a lot of people might not know the actual letters, English letters, we use what we call the E. So we always tell them, where is it opened? Up, down, right, or left. And sometimes you have children, they can actually put their 3 fingers and direct them to either to the side, up, or down, depending. And then when you have infants, then you just show them this nice photo. They would say a birdie, a horsey, a cake, a car, and so forth. And these are actually different size targets. There is a standard distance from the eye and what we call a Snellen charge. And you usually say if a person has excellent vision, you say 20/20. So what you're using there is the feet. Or you say 6/6, and here you're using the metric system. So please go and read on the 20/20 vision and the 6/6 vision. Now, and we also have near visual acuity testing. I just put it up only for completion. And then, unfortunately, if a patient can't read the chart, we will refer to them as either counting fingers, hand motion. Counting fingers means like you put the fingers very close to their face, then hand motion is you move it back and forth, and some of them can't even see your fingers or your hands, and we refer to them as light perception. And then, God forbid, if they don't see anything, even though when you shine the light, they will not be able to know if there is a light on the eye or not. And this we refer to as no light perception. This is what we call total blindness. The pupils are really very important when we as ophthalmologists do our examination. So you have to know the shape of these pupils, the reactivity to light. We always shine a light. You also have to know their size, and then of course reactivity to accommodation. when they look near, and I'm going to be talking to you more about that when we talk about strabismus. As you can see here, I just put this baby, this child up, and here it shows you the red reflex and no reflex, and I'll be talking more about that when we talk about pediatric ophthalmology. The slit lamp examination is really a very integral part of our examination as ophthalmologists. It's usually table mounted. As you can see, I'm sitting on a chair, and so is the patient. It's a binocular microscope, as you can see. Both my eyes, this is me, both my eyes are actually into the scope, and it has a very special illumination source. You don't really have to know anything other than what a slit lamp is, and for us as ophthalmologists, we use it. It's really just a linear slit lamp, a slit beam of the light that's projected into the globe, and usually all the way on from the cornea onto the anterior chamber, on the lens, then into the vitreous, and then either onto the optic nerve or macula, which we will be discussing later. As I told you, this is just an orientation to ophthalmology before we actually start our 5 lectures. Again, the slit lamp, you actually can see the anterior half of the globe, which we refer to as anterior segment. So this is your cornea. If you guys are wearing a watch, please look at your watch. The watch will have a glass part. You don't see it, but you know it's there because it's crystal clear. This is equivalent to this, what we refer to as the cornea, the crystal part of the lens. Between your watch, if you look at your glass, then you'll see the colored part, which is the basis. This is actually what we refer to as the pupil or the iris. In between the glass and your colored part of your watch is an actual compartment. This is what we refer to as the anterior chamber. And within the anterior chamber, the aqueous humor circulates. So here is your slit lamp. It's actually table mounted, and we actually shine a light, as you see nicely here, on the patient to be able to see the cornea, anterior chamber, iris, and this is actually your lens, the ocular lens, which is crystal clear. Behind it, of course, would be the vitreous and then your retina. Another important part of our exam is what we refer to as the tonometry. And the tonometry is simply measuring your pressure. You have to remember the globe is considered a closed compartment, and there's a constant circulation of the aqueous humor. I would like you to go back and read on the aqueous humor where it is produced from the ciliary body and how it circulates into the eye. Because it's a closed compartment, this maintains the shape and relatively the uniform pressure within the globe. Please remember, this is really very important to know your normal pressure, which is from 10 to 20 millimeters. A really key point to know this. There are many ways that we can measure the intraocular pressure when we refer to as tonometry. You have the Schiot's, you have the Goldman applanation, just simply that you know about them. We have something called the Tonopin. I like this simply because you can carry it in your pocket. You also have the Perkins, again, another mode of examining. And then, of course, most of you, if you've gone to an ophthalmologist, you've had the air puff where we actually, whoosh, it's an air that measures your pressure. Now, for you, you must know what an ophthalmoscope is. Please learn to use it. It's not because you're going to be ophthalmologist. An ophthalmoscope is an important instrument that every specialty, wherever you go into, you have to be able to master it. I remember that I bought my own as a student because I would carry it with me, and any chance that I could examine an eye, I would do it. It's a handheld instrument. It's really very important part of any general medical examination Nothing to do with ophthalmology, so learn it. The nice thing about it, it is portable. If you, as a fifth grade medical student, if you haven't mastered the ophthalmoscope, then you have honestly failed your course, because you do have to know how to use it. And you will be having tutorials, hopefully when you get to the 5th year, on the proper use of the ophthalmoscope. We, as ophthalmologists, don't really use the indirect ophthalmoscope. We leave it to the non-ophthalmologists. We use what we call the indirect ophthalmoscope, and this is really very important. We put it on, mounted on our head. It just gives us much better view, if you will. This is me examining one of my retinal patients. We also have special lenses. You don't have to worry about them, but we do use special lenses for all the evaluations. If remember, I explained to you, here's your cornea. It's this light, this crystal part. Then, of course, you have your anterior chamber. Then you have your iris, which is the colored part. Then you've got your little opening, the pupil. Behind the pupil sits the lens. Between the lens and the optic nerve, or between the retina, is also a space, and we refer to that as the vitreous, where a gel sits there. And this is all your retina. This is your macula I talked about, which is in charge of your central vision. And then, of course, you have all your vessels, which is really very important to be able to understand the posterior pole. This shows, remember, previously I showed you the optic disc, the optic cup, and I showed you the vessels. Unfortunately, smack in the macula is a hemorrhage. So I will tell you this patient is practically totally blind because the hemorrhage, unfortunately, is covering the macula. Then we have the retinoscope. This is also very important for the retinoscope because we have to be able to understand the different refractive errors. And the retinoscope has nothing really to do with examining the retina as the ophthalmoscope. It just takes the reflex off the patient's retina, and using the retinoscope, I can tell if you're no refractive error, if you're myopic, if you're hyperopic, and if you have astigmatism. So please understand and read on myopia, hyperopia, and astigmatism. And it's this retinoscope, and you will never be asked to use it or be able to know it. I just put it up as it could be part of your multiple choice questions. So here we are examining a patient with the retinoscope, nothing to do with the retina, simply to understand where what his refractive error is and if he needs glasses or not. So I'd like to thank you all. This was just a simple orientation. We haven't really started. We will be starting our 5 lectures that I mentioned in the orientation. I just gave you this as an appetizer so that you can understand more or less more of the ophthalmology. So once again, thank you all for your attention, and I will be joining you later for the visual impairment, which is our first lecture.